thank you everyone for coming. It's been a really lovely event so far. And today, I want to talk a little bit about medical AI and the ethics of medical AI. I'm going to start the first 20 minutes or so, a bit more of a kind of general overview of the area, before turning to some insights from part of my PhD research, which is focused on the Transplant Benefit Score and how clinicians and patients have experienced that. So I'll get on to that shortly. But very briefly, what do we mean when we talk about AI? Well, as Callum said, it's kind of a big catch-all term that really includes a whole range of technologies. And it's sort of more, when I think about the use of AI, I think of it more, I suppose, of a term of art than a term of science. It's not really picking out anything specific. It can be used quite nebulously. Sort of some interesting slogans about, well, once something starts to actually work, then we stop calling it artificial intelligence. Artificial intelligence is always this thing in the future. Things that 30, 40 years ago that would have been considered somewhat fantastical, even certain technologies, satellite navigation, systems that can play chess and go to superhuman levels of performance, that they exist now. They can all be considered artificial intelligence. So these kind of things that perform tasks that we usually associate with requiring human intelligence. But when we think about AI in healthcare, or at least in recent years, the major growth in the field has come through this particular type of artificial intelligence called machine learning. And machine learning is one type of AI. It's a type of AI that uses historical data sets as inputs to make output predictions without explicit human programming. So rather than a team of statisticians or clinicians in a healthcare context designing a statistical model that's kind of pre-weighted and calibrated. So, okay, when this variable is at this level, it produces this kind of score, and this is how these different variables interact to produce this kind of score. And it's kind of been explicitly programmed by human agents. Machine learning it has a kind of particular system architecture, but it learns patterns and identifies correlations and makes predictions without that explicit programming. And it usually does that so with huge amounts of data, perhaps more data than individual human agents or even teams of human agents could use to create a more traditional statistical model. And that's where its supposed kind of power and predictive capacities come from, the fact it can take so much data into account and notice and identify correlations and patterns in data that human agents might not be able to. It's also where, and we'll talk about this a little bit later, as Callum mentioned, the kind of black box nature of some machine learning technologies is said to arise from, that because of the vast amounts of data involved and because of the lack of explicit human programming, you can't go to someone and say, can you give me the code for how this model is producing this? Then it can be difficult to exactly explain how you put all this input data in the clinical context. It might be patient health data. And we get this output, and perhaps it could be a clinical prediction or a diagnosis or a treatment recommendation. It can be difficult to exactly identify how that stuff in the middle happens. And just there, I won't go into too much of the technical detail of how machine learning models work, but there's various different forms of system architecture that could be used. On the bottom, it's a kind of random forest approach, which is where you kind of have an assemblage of lots of decision trees, so sort of like if-then rules. If a patient has this particular variable, it goes down this path and it creates this prediction. But a random forest could use hundreds, even thousands of these models combined, aggregated to create these kind of predictions. And then we have deep learning. Deep learning is where a lot of the technologies that are causing the most kind of hype are based around. So, for example, ChatGPT uses deep learning system architecture, which tries to simulate sort of neural networks in terms of the number of different computations and refinements and adjustments that go in when you create the input, put in the input data, goes through these different nodes in the middle of the machine learning model where the predictions are refined and then eventually comes out with this output. And again, relating that to the complexity of this is a very, we've got 4, 8, 12, 16 little nodes in the middle. These can have thousands, millions of nodes doing these kind of calculations, again, making it really hard to work out exactly how the inputs produce the outputs on the other side. And in healthcare, there's a range of different uses for machine learning technologies. So for example, you might use a chatbot to interact with a patient as a kind of replacement for a human agent. I think when I rang NHS 111 a year or so ago, I actually did have a chatbot interact with me, and I gave a few clinical symptoms, and then it triaged me, so it referred me to a more specialist human practitioner. And chatbots can be sort of based on large language models. You might be very familiar with the ChatGPT technology, where you can kind of have conversations with this model, and it will produce answers. So for example, that also could be used in a clinical context to automate a lot of administrative tasks and clinically important tasks. So you could use large language models to automate note-taking in a clinical appointment. So rather than having to take notes as it's ongoing, the large language model produces the notes at the end of it. It could be used to summarize, so create a brief summary of, say, a very long conversation or a long clinical encounter. Could be used to draft referral letters. So for example, a large part of a clinician's job often is writing letters to, say, a specialist, sending a referral from a GP to a specialist. These large language models could be used to automate some of that process, or indeed collating data from lots of different sources to produce maybe easily accessible or readable summary of that information for the clinician or a patient. Also, AI is very, very good. One thing it's very, very good at is image recognition. So in the kind of toy examples, you can play around with sort of image classifiers. So is this image of a cat or a dog? And it's been trained on thousands, millions of images of cats and dogs. And it's not like it has necessarily, if it's a machine learning system, it doesn't necessarily have a sort of hard and fast set of rules that I know, okay, if this is there, it's a cat, if this is there, it's a dog. But it's identified the patterns in the images and can then be used to classify new images according to the learning that it's done on the past data sets. And obviously in healthcare, there's a huge amount of image data, radiology data. So you can use machine learning technologies to try to identify suspicious signs in an X-ray, perhaps signs of cancer. You could use it as dermatology data to identify suspicious lesions and then be referred to a clinical specialist, for example, if something suspicious has been found. So the idea we could maybe automate some of these kind of radiology tasks to free up time for radiologists to spend more time on the tricky cases. That's one potential use. Then we have things like AI treatment recommendation algorithms. So I've mentioned on the board IBM Watson. Have people heard of IBM Watson in the room? So it was quite famous a few years ago, particular technology, IBM Watson for oncology. Speak more a little bit about that later. But there was a great deal of excitement around its potential to make personalized treatment recommendations for cancer patients. So you'd be able to input patient data into this system, and it would the idea was that it would produce a personalized treatment recommendation based on that patient's clinical symptoms, their demographic data, all this kind of patient health data. We've also got ambient AI. Might be a bit less familiar with that. It's sort of less kind of well-known than the image recognition technology or the large language models. Ambient AI is basically AI built into the hospital environment, sort of like physical sensors, so that it could identify, for example, if a patient was identified in a hospital room as moving in a particularly strange way that might indicate clinical distress. It might give an alert to a team of nurses or team of clinicians to go and check on that patient. There's a lot of interesting work in this space around how you do that without, obvious kind of privacy violations, about how you can detect movement and clinical distress without sort of taking videos of people, and how you can keep those private. So that's one particular use. And then there's clinical prediction models. This is kind of where my research focuses mainly on. They've been used in healthcare for a huge range of tasks. So clinical prediction models we've used to assess in-hospital mortality, to predict patients' likelihood of being readmitted once discharged from hospital, to identify cancer patients who might be at high risk of mortality, to identify patients who might be at high risk of HIV acquisition, who could then be given PrEP to prevent that. And you could use that to also kind of allocate scarce healthcare resources. So I've read papers of machine learning models designed to more accurately predict which patients are likely to die on the transplant waitlist, to be used then to allocate the scarce organs that we have for that kind of need. So that's a big range of these kind of technologies. And I think it's fair to say that they're not just considered in this kind of like neutral way where maybe they're good, maybe they're bad. There's been historically quite a lot of hype around the possibility of AI machine learning in healthcare. So I'll just go through these. Don't need to worry about not being able to see them quite, because some of them are quite small. But you see this even in some sort of academic articles where you'd normally expect a kind of sort of sobered, measured tone to be used. You know, I've got an article here just from last year about revolutionizing healthcare, the role of artificial intelligence in clinical practice. So this suggestion that AI is not just going to be some new tool or technology at the disposal of doctors, but it could in fact be revolutionary for the field. This is Geoffrey Hinton. He's known as the godfather of AI, one of the godfathers of AI. He did a lot of the foundational research into kind of deep learning, the paradigm that's very prominent in the machine learning space today. And he famously said, and Callum sort of mentioned this earlier, he famously said back in 2016, people should stop training radiologists now. It's just completely obvious that within 5 years, deep learning is going to do better than radiologists. So it's now 2024, not 2021 as he predicted. And that prediction has perhaps not yet come true, although as Callum said, it is perhaps influencing the kind of careers that some clinicians go on to choose to do, the kind of way health systems are allocating their resources. This is from the Department of Health and Social Care. It says, AI at the forefront of efforts to treat coronavirus patients. Claims that patients with COVID-19 are set to benefit from faster treatment, improved outcomes, and shorter hospital stays thanks to the use of the latest artificial intelligence. So that was in 2021. So at that point, the NHS was doing some attempts to create these kind of models that could be used to predict severe COVID, to better diagnose COVID, to recommend treatments. And the hope was, as published on the government website, this is going to really have a huge beneficial impact on patients. And here again, IBM Watson. So this is IBM Watson for oncology. IBM's new supercomputer has been hailed as the future of healthcare, and it can even devise a recipe for a mean stew. Watson is an AI system that uses natural language processing. You can ask it a question in everyday English, and machine learning where the computer learns without having to be programmed with new knowledge. So this was an article back in 2014. So IBM Watson was designed as a tool to recommend treatment for cancer patients. It was trained on data taken from Memorial Sloan Kettering Hospital in New York, one of the top cancer centers in the whole of the world. And it was sometimes referred to as Memorial Sloan Kettering in a box. So the idea being you'd be able to get all this expertise trained on the recommendations of these elite cancer specialists and be able to use it in clinical contexts where maybe that expertise was not so readily available. So it could be particularly useful in a sort of more resource-poor environment where maybe we didn't have that level of specialist cancer care, but we still wanted to have access to these kind of expert recommendations. So there's a real sense, when you read some of the literature, you read some of the media reporting, that AI is going to have this incredibly positive impact in healthcare. Unfortunately, the record has been a bit more checkered than that. That often this hype is also accompanied by some degree of harm. So again, very small, don't worry, I'll go through each of these in turn. We start with the top left example. A hospital algorithm designed to predict a deadly condition misses most cases. A new study found that it also had many false alarms. So this refers to the Epic is the company that made it, its sepsis prediction model, which is currently in use in a very large variety of US healthcare institutions. It was found to be failing in two very different ways. It was found to have a very low level of sensitivity. So it was not always able to correctly identify an individual who did have a risk of developing sepsis. But it also was found to have quite low levels of specificity. So it was also inaccurately identifying patients who were not likely to get a risk of developing sepsis and triggering interventions towards those patients. Now, it's only after several years of this model being used that these kind of studies actually took place to identify these failings in the system. And obviously the risks of that kind of thing are very, very clear. If it's causing a lot of false alarms, identifying patients who actually aren't particularly in need, then it's a waste of clinical time in terms of interventions being triggered that aren't necessary, might lead to staff having a greater kind of disinclination to engage with it at all. It's not really producing the kind of results that we want to see. And we see, this is a very commonly used algorithm that had a great deal of promise, a great deal of hype, but then actually has not really, in a clinical context, shown the evidence of benefit that we might have hoped from maybe some headline figures over its accuracy is this, it can save this much time. Well, when it's actually working in clinical care, it's not shown that. An interesting one in the middle around patient consent. You might be interesting to talk about this. You might think this is no problem at all, and this is totally reasonable, but it was an interesting case. An invisible hand, patients aren't being told about the AI systems advising their care. So this is a Stat News report from 2019, found that since 2019, tens of thousands of patients hospitalized at one of Minnesota's largest healthcare systems had their discharge planning decisions informed with help from an AI tool. But few, if any, of those patients had any idea that AI was being used involved in their care. The frontline clinicians generally did not mention that AI was being involved behind the scenes in informing these kind of decisions. Now again, not necessarily really interesting to talk about this, whether you think that's ethically controversial or not. Do we expect clinicians to tell patients all the details about all the clinical tools that are informing their recommendations and decisions? Do we expect them to say, I know that because I read a journal article back in 2018 that made me think that, or I had a conversation with my colleague in the cafe and that's why we're thinking we're recommending this, or is there something different about the use of AI that means people should be informed about it? In the bottom left, middle left, racial bias found in widely used healthcare algorithm. An estimated 200 million people are affected each year by similar tools that are used in hospital networks. This is one of the most famous cases in the kind of ethics of AI in healthcare literature. It found that it took an investigative report by some academics in Stanford to identify that this software being produced by the health services company Optum, which was used to manage the care, this particular algorithm was being used to manage the care of over 200,000 patients, 200 million patients across the US, was found to be being significantly biased against black patients. So how did it work? Well, the idea behind this tool was that we're going to use a machine learning algorithm to aim to predict the future healthcare needs of patients that were enrolled on this Optum Health program, with the goal of directing patients towards, directing extra additional care resources towards those that the model predicted were going to be at most in need of those kind of additional resources the next year. So why did it go wrong? Well, it wasn't explicitly some racist algorithm that took into account race and deprioritized those that were non-white patients. Instead, what happened is we had this kind of thing that we call in the AI ethics literature of label bias. So what was happening was that they had this data and they had to make a prediction to allocate these resources that they had. But to predict who is most going to need healthcare next year is quite nebulous, quite hard to define quantitatively. But what they had very good data on and could make very accurate predictions on the basis of was predictions of healthcare costs and healthcare spending next year. So it could identify quite well which patients were going to incur the greatest healthcare costs in the future and identified resources towards them. However, particularly in the US healthcare system, it's very well known and very well researched now that non-white patients, particularly black patients, are likely to have lower healthcare spending, lower healthcare costs, for the same amount of clinical need as white patients. Because black patients in the US are less likely to have as high quality insurance or insurance at all than white patients. Biases amongst clinicians mean that they may not be recommended the same level of intensive medical treatment as white patients. Issues of socioeconomic deprivation mean that they might not be able to access the same level of healthcare and therefore have lower healthcare costs the next year. So the model was very much being very good and unbiased at predicting healthcare costs, but an equivalently ill black patient and an equivalently ill white patient, the black patient would be deprioritized for treatment on the use of this algorithm. And it was only this big study by these Stanford scientists and computer scientists and clinicians that found this out. Optum, I suppose to its credit, was open about its algorithm and they did this algorithmic audit. Other companies are not always so open, and indeed, I think several companies took the lesson from that, not of let's have greater transparency in how these kind of tools work, but actually, this was a real big scandal for them, and let's make it much harder for people external from the organization to come in and dig around in the algorithm, identify these kind of issues. COVID, at the very bottom left. This was a meta-analysis from 2021 on 2,212 studies. After quality screening, those 62 studies were included in the systematic review. So 62 studies of machine learning tools designed to improve the COVID response, to help patients during COVID. Our review found, the highlight bit says, our review finds that none of the models identified are of potential clinical use due to methodological flaws and or underlying biases. So none of these models that they looked at had any positive clinical impact for the COVID response. You can imagine why that might be the case. COVID is a quite rapidly changing condition that is evolving over time. Data is being collected for these models in very resource-strained and clinically intensive periods that may be being used, gathered in one regional geographical clinical context and then transplanted into another when the model is being used on a quite different patient demographics, for example, in a different clinical environment, when the disease is different. Just found that actually these models weren't very helpful, well, at all helpful for patients. And finally, here's a study, again, a bit of investigative journalism. I'd also really recommend that this is a really good place to go for ethics of AI and healthcare work. Some of the best work is not really done in academic papers. It's done by investigative journalists going on the ground and finding out how these systems are affecting people in the real world. The pain was unbearable, so why did doctors turn her away? This was an investigative report into an opioid addiction prediction algorithm. It found that some patients were being denied essential pain-relieving care with no recourse to appeal because the predictive machine learning algorithm that was making these decisions was proprietary. So proprietary meaning that it was the intellectual property of the company that produced it, and they had no interest in letting anyone see how the algorithm was making the decisions. And although it was being used, sort of advertised as this is an advisory algorithm for clinical judgment, for clinicians to make these judgments, insurance reimbursement decisions and clinical practice basically meant that doctors had to go along with the recommendations of the algorithm. So this is an interesting case. The story in this case is a patient who was having very bad menstrual pain. I think she suffered from PPMD. And she received opioid treatment in hospital, which was kind of relatively routine for her. And then halfway through this course of treatment, this treatment was stopped. And the clinician said, the algorithm's kind of identified you as high risk of developing opioid addiction, so the treatment needs to end. And she had no idea why, and the clinicians had no idea why. And it was only after this quite lengthy investigative process that they found enough out about the algorithm to know that one thing it took into account was prescriptions for pets. So she had a dog who also was prescribed opioids, but this was flagged by the system as a particular warning sign. The idea being that people that might be addicted to opioids and maybe getting these false prescriptions for pets to use for their own use. And so that was the thing that they think the model was being triggered as. But it took a very, very long, this was not easily accessible. This took this investigative report for her to find out. And she had no way of appealing this decision. So that's kind of AI harms. So what should we learn from this kind of cycle of hype or harm? Well, I think there's a couple of things. I think one is the need to not just think, okay, I've read an academic paper in a machine learning journal that says, I've created a clinical prediction model and it's got 98% sensitivity, 97% specificity, and then a doctor or a healthcare institution goes, well, that's an amazing increase on the accuracy of the clinicians at our hospital. Let's get this in right away and plug it into clinical practice. Because how things work in the kind of relatively constrained context of the training of the model and the publishing of the results is not necessarily how they're going to work in the real world. And it's not taking into account all the human factors that Callum mentioned earlier about how do we talk about this with patients? How do clinicians interact with this? Do they have control over it? Is it operating independently of them? How is the model's performance going to change when it's put into this context that may be very different from the context it was trained on? All these kind of questions need to have this kind of investigation clinically on the ground. And also, I think that what was shown hopefully on the last slide is we have this really nice mix of what might be considered more quantitative ways of assessing the success of these models. So we had the meta-analysis that analysed the impact of the COVID tools, but we also had some investigative journalism. We had some studies that were focusing more on the kind of lived experiences, the way people were interacting and how it was affecting clinical experiences and workflow. And that we need to have both of these kind of methods when we're investigating the impact of these technologies. So I suppose that brings me on to the second half of today, as I start to talk about the Transplant Benefit Score. But just briefly, I was thinking, well, okay, how can the UK prepare? And the reason I say that is because AI is not yet routinely deployed in the NHS to the extent I think that it is in some US healthcare institutions. Now I say routinely because there is some happening, absolutely. So for example, there's the NHS AI lab, which operates now to bring government healthcare, academic providers, technology companies together to be trialing out uses for AI in healthcare in the NHS. Just recently, I saw a report saying that £21 million had been allocated to 64 NHS trusts across England to roll out AI tools to speed up the diagnosis and treatment of lung cancer. And the use of AI is already being used in apparently 90% of hospital networks, stroke networks in England, to try to reduce the amount of time needed for victims to receive treatment and cut waiting times and assist in diagnosis and treatment. So it is happening. But I think in a really good way, it's happening quite gradually and it's happening quite iteratively, and it's not being, there's lots of things being trialled at particular hospitals. I know there's a very prominent team of AI researchers at Addenbrooke's Hospital in Cambridge that do kind of trials in Addenbrooke's. They're not necessarily sent out to every NHS hospital all at the same time, so it's happening gradually. But that's not to say that there isn't a lot of algorithmic systems already being used in healthcare. There's not a lot of technology being used in healthcare. And I do think we can look at some of the currently implemented technologies and think about exactly what lessons they might have for the implementation, more widespread implementation of machine learning in the UK. So that's where, as I say, the second half of some of my research comes in. So as part of my research, I've been thinking a lot about the Transplant Benefit Score. So the Transplant Benefit Score should stay very upfront. It is not machine learning. It's not artificial, depending on how inclusive your definition of artificial intelligence could be, maybe you could claim it was, but it's certainly not machine learning. It's a regression model that's pre-weighted and pre-programmed by a team of clinicians and statisticians. So it's not doing the kind of machine learning approach, but it was introduced in the UK in 2018 to allocate livers for transplantation on the UK transplant waitlist. It is a far more algorithmically complex method than the previous method. Previously, livers were allocated regionally to regional transplant centres. So if in Scotland a donor died, their liver was usually sent to Edinburgh. And then it was at the discretion of the clinical team there which of the patients on their wait list received prioritisation. They'd very much rely on these clinical tests called UKL tests, which take into account just a few recipient clinical variables to estimate the severity of need for transplantation. So it would be very heavily informed by that, but it would be a judgment of that clinician when it was offered as to who that liver went to in their regional transplant centre. Now, a large portion of the UK's donor livers, the DBD livers, the death by donor by brain death livers, are allocated using the Transplant Benefit Score, which takes into account 7 donor factors and 21 recipient factors. So that's a significantly increased number of clinical variables being considered. And also, it's done based on a national waitlist. So everyone's data is placed into this national computer database. And when a donor liver becomes available and the data is paired with the data from the patient recipients, the person at the top of the list is offered that organ nationally. So the livers could come from anywhere. If that is turned down by the transplant centre or the patient, then it gets offered to the next person down, and so on. There are more complications to this, but that'll do for now, I think, in terms of the explanation of the system. But crucially, because of that way it's matched, it's not left as much at the discretion of the individual clinicians. They can't say, oh, not that patient, I actually think it's much suited for that patient. It goes back into the system and then gets offered to the next person on the list. So, I should note quickly that it's now the subject of a reasonable amount of media attention. So this is a BBC News article saying young people waiting 4 times longer for liver transplants. So one consequence of the system, which we can talk about in the Q&A, is that it just seems that young patients are waiting a lot longer than they were under the previous system to receive transplantation. Financial Times article, algorithms are deciding who gets organ transplants. Are their decisions fair? This is a very big article doing a deep dive into one patient's experience of an algorithm would be making the life or death decision, and her sort of struggles to understand the system and understand why it wasn't prioritizing her very highly. So it's now media attention. Interestingly, this BBC News article was on the front page of the BBC News website, not the lead story, but one of the sort of main stories that day. But then it was the same day as the Lucy Letby verdict was announced. So it kind of immediately became far less the most important healthcare story of that day. So what did I do? So I interviewed did a series of interviews with liver transplant patients and staff regarding their experiences of TBS. So I was asking them questions around their understanding of the system, whether it affected the kind of medical decisions they made, if they had any disagreements with the system, whether they were enabled in any way to kind of contest their prioritization, how it affected the clinician's perspective of their role with that reduced level of discretion they had about deciding where the DBD livers went to. Just for time, there's lots of complications around DBD livers, DC livers, death by donor by cardiovascular death, which we can get into, and it'd be great to talk about that more generally, but I'll just keep it relatively simple for now. And I did 20 patient interviews and 9 staff interviews around the experiences of patients and staff. And it's to the knowledge of us as researchers the first piece of kind of in-depth qualitative work on TBS. The people that the statisticians that are involved in the design of the algorithm, they're constantly, and clinicians, they're constantly doing quantitative work estimating the impact of deaths on the wait list and how long people are waiting and so on, and how long people are surviving post-transplant. But this, we think, is the first piece of qualitative work on it. And just briefly, kind of going back to the machine learning, why do I think that there's anything interesting to find out about from these interviews for machine learning? Well, firstly, because as we'll talk about in a moment, as I'll mention in a moment, when we think about the black box problem that I talked about at the start, I think issues around understanding and complexity and opacity and transparency go way beyond just, oh, there's some spooky stuff happening in the middle of the machine learning algorithm that we don't know about. And these interviews, I think, reveal some of those forms of opacity and transparency in ways that are useful when we think about machine learning. The second thing is, I think there's a narrative around machine learning that sometimes is quite common of it being very autonomous and decision-making and separate from human control and oversight. And some people see that as a positive. You're like, okay, well, if we've got this much more accurate system, if we think this system is actually more accurate than human clinicians, then why shouldn't we want to give it that kind of control and oversight and decision-making authority? But even in a system like TBS, where it does have a degree of autonomy in the allocation decisions it's making. Talking about it in it is perhaps problematic, given it is designed, of course, by human statisticians. But even here, we can see various points at which humans are constantly intervening and adjusting and adapting for what they perceive to be the strengths and weaknesses of that system. And that, I think, should be a lesson for machine learning designers to think about how a human's going to interact with this system, even if in theory it's got a degree of autonomy. And finally, just for the purpose of today, there's loads of stuff we can talk about with TBS. Very happy to do so. But just for the purpose of time, I just thought it'd be interesting to end with a couple of quotes that suggest that trust is not always the most desirable attitude to hold towards these systems. And sometimes a lack of trust can be really positive. So briefly, talk about the black box problem already. So we don't need to go into this hugely now, but the black box problem, this is a paper by Wadden, 2021. The black box problem in healthcare AI occurs whenever the reasons why an AI decision maker has arrived at a decision are not currently understandable to the patient or those involved in a patient's care, because the system itself is not understandable to either of these agents. Now, the way that's most commonly thought about is how we've described it so far. No explicit human programming, so many layers of complexity in the internal mechanism of the algorithm, really hard to work out how the inputs end up in a particular output. But that isn't the only form of opacity that we might want to be concerned of. This is a paper, this kind of framework comes from a paper back in 2016 by the computer scientist Jenna Burrell, talking about 3 different forms of opacity. She describes intrinsic opacity as kind of what I've just mentioned there, just the actual way in which the outputs are produced by the inputs. And for a machine learning model, those might be quite opaque. But there's 2 other forms of opacity that she identifies that algorithmic systems can have. There's opacity as technical illiteracy, that patients or staff or regulators or hospital administrators might lack the capacity to comprehend exactly how an algorithm is working, even if it is in theory interpretable. That they might just not have it explained to them in a particular way or have a way of understanding it that makes sense for them that means they can actually get to grips with it. Because an algorithm might be theoretically interpretable. I could produce you like 45 pages of code for how an algorithm works, but it's not necessarily going to be much use for me or you, perhaps, in understanding how it's making decisions we care about. And then finally, there's this third one, intentional opacity. This refers to the idea that decisions can be taken by agents over what information isn't made available to scrutinize the algorithm. So for example, back in the opioid addiction prediction algorithm, we saw that it was really hard for this particular person to understand why she wasn't getting any more of a treatment, because the company just decided they were not going to make that information public. It was proprietary information, and you don't get to look at the algorithm because it's our kind of it's in our financial interests for it to be kept just to our knowledge. And so here's another reason why I think looking at other algorithmic systems like TBS is useful for machine learning. Because these 3 things can all be involved in machine learning. And although TBS is not intrinsically opaque because it's designed by statisticians and you can find out how the TBS produces the outputs from particular inputs and how the weightings of the variables are done and so on. What I think my interviews revealed was that there was quite a lot of difficulty with some patients and staff for understanding how it worked, even if it was in theory interpretable. And also there were certain decisions that were made about how much information would be provided to patients and staff about how it worked. So just briefly, a few quotes from some of these interviews that show some of this difficulty that patients had with understanding it. So this one patient said that when they knew about the MELD score, the UKL score, that's a score that just takes into account, I think it's 4 clinical variables to a patient in a very simple equation that kind of estimates their severity of illness. They were able to identify that and see what it was and compare it. But then when we found out about the TBS, which as I say takes into account I think, 29 patient and donor variables in total, it just made no sense to me at all. I was like, whoa, the shutters went down sort of thing. And I thought I'll try and work out my TBS scoring. Couldn't do it at all. But I never asked. I never asked at my clinic appointments what TBS was, never asked at all. So there's this interesting way in which the complexity of that algorithm for this patient was just a barrier to them even asking questions about it or understanding it in much depth. And although I don't have time to talk about it in this presentation, very happy to take any questions about the kind of tricky information about what patients would be using that information for, why it might be valuable for them, and so on. Here's another interesting quote from a patient. It's kind of hard to understand because I don't think, like the consultants know much themselves. I think they're only feeding a computer, aren't they? The computer is doing the work. So there's a perception amongst some patients that staff themselves didn't have a great grasp on it. And although I don't have quotes on this particularly, I can say that there's quite a lot of variance in the degree in which staff understood the system. Often related to clinical roles. For some members of staff, it just wasn't as central a part of their role to understand that. Some members of staff I interviewed had a great deal of role in sort of designing and testing and validating TBS. So there was a lot of variation in exactly how much staff understood it. But obviously, if the staff that you're interacting with maybe don't understand it fully, it's going to be very difficult for a patient to get that kind of understanding of why it's making the predictions and decisions it is. Interestingly, one staff participant said that, sort of referring to this idea that to really explain something, you need to kind of have it kind of like a 14-year-old reading level to clearly convey that to different people. He says, I think you need a university degree to understand the TBS, which probably is accurate given how complex a regression model it is. And here's an interesting final form of opacity. The opacity that kind of is created by metaphors. So it's interesting the kind of language we use. Because this staff participant said that a lot of people still think it's like standing in a queue to buy your groceries in Tesco's, and it's not like that at all. There's not a queue. It's almost like chucking a ball into a crowd, and it's whoever gets the ball first gets the liver. So some kind of misunderstandings perhaps being created by the metaphor of the wait list. This is an idea that we're queuing, that you're just getting further and further up. Your priority is increasing the longer it is, which isn't how it works at all. I spoke to one patient who described this being quite confusing for them, but until they start to think about it in terms of the database rather than the wait list, and that helped them conceptualize it a bit more clearly. So these different forms of challenges for explanation, for comprehension, that come with the use of complex models. Here's an interesting picture. This is a calculator for TBS. So this allows you to put in the different patient and donor variables and produce a TBS score based on that to give you a kind of nice visual interface for understanding TBS. Now, interestingly, for a period at one transplant centre, this was available for staff to use. And at least speaking to some of the staff, they suggested it did, was sometimes something they used to help understand, how the patients were doing and some kind of role in the clinical process. But because of concerns over medical device regulation, that if this was going to be in any way kind of intervening in being used in clinical care, it wasn't actually gone through that whole process of medical device regulation. It was just done by someone, a member of staff who had a great deal of experience and was involved in the design of TBS and understood it very well. And also because the TBS system has changed somewhat in response to identifying weaknesses of it. It's kind of iteratively improved over time. They were worried about being out of date. Staff no longer have access to that. All you can actually access now, if you go to that same website, is this much more simple calculator. And I'll just read what it says in red. Basically, you can just put in like sample patients. You can't put all the variables in yourself. I'll just read what it says in red. This is a medical information app designed by clinicians to aid in understanding of the TBS. Example cases are provided. It is not possible to enter actual liver disease values. It is not to be used for any diagnostic or treatment purposes. So staff lost access to that kind of quite sophisticated system. Now, I think there's reasons for not having that access are very good, but it does obviously affect the kind of explanations that staff are able to have themselves or provide to patients by not having this kind of tool available. And a few staff mentioned this. They said, it's really hampered in terms of explanations by the fact there's not a very good graphical tool you can use to explain it to patients. And one staff patient thought that patients should be able to calculate TBS. And they can't do that at the moment, again, potentially because of the lack of this kind of thing. So that's an interesting context where decisions are made about what levels of explanation are available to people, and that affects the ability they have to comprehend these kind of algorithmic systems. Now, of course, I'll just mention very briefly, and maybe this is particularly unique to transplantation, but it might go across to other medical contexts, given that however explainable a model is, there'll be things outside of it or things that model is related to that there's still unknowns, that there's still uncertainty. And so maybe there's always going to be a kind of unresolvable opacity around the use of these technologies. Transplant is really obvious. How long will I wait? I could have the most simple, transparent model you could ever imagine, and we would still not be able to answer the patients, how long am I going to wait for an organ? Because you're waiting, tragically, for someone to die that is a match to you for that offer to be received. So even a fully transparent model must account for the fact that there's always going to be these kind of unknowns. Again, really don't think there's much they could have said more about the explanations, because you've got to wait like everyone else. Met one patient thinking, if I'd got a bit of an estimate, that would have been great, but I suppose it's a bit of a catch-22, because you never can really know whether that's going to be in the next 2 months or not. And actually, interestingly, with TBS, the fact that it combines the donor and patient variables means that you're never going to have a full understanding of what the offer is until that match is made. So telling a patient on a wait list, your score is this, well, it's always going to be incomplete because you're waiting for that donor organ to complete the score. And I think that might be an interesting problem. The more sophisticated machine learning technologies become, the more kind of variables that it takes into account, the more it's taking into account various different sources of information, then is there always going to be a kind of opacity. And as I'm coming up to time, I'll just very quickly mention that there may be more human control over algorithmic systems than first appears. So in this Financial Times article, they mentioned that when Jess was trying to investigate a score, there were no humans, they were told that there were no humans involved in overseeing or overriding the score, and there was no appeals process, even at a physician's discretion. Now, interesting, I think my interviews revealed something a bit more subtle. I'll just give one example of this. That staff did, if they were aware of a patient's score not being a very good representation, they did have the ability to kind of negotiate with other local transplant centres over the supply of DCD livers that they still receive, the donor by cardiovascular death, which were still regionally allocated and not offered in the national wait list. So there was some potential for a bit of kind of negotiation for patients that they knew were not being advantaged. I'll just skip ahead to this. There was a temptation, I think, to think of like scores and algorithmic scores as kind of unbiased and completely objective and completely outside of human control. But obviously, what you choose to input into that data is going to have a big role in what prediction is made and what comes out of it. So the choice of what is listed as a patient's primary pathology in the system influenced the score. And so that is a kind of human choice that comes into the system that in this staff interview, they realized that they thought this patient was very sick and the score wasn't taking that into account. So they made this decision. They had to go through a quite rigorous process about it, requesting this decision to change the primary pathology that was listed which made that patient's score, prioritization score, somewhat higher. And I'll just finish off because I'm about to run out of time. That trust in algorithmic systems, a final lesson I think we can take is that it's not always a desirable attitude. This is a great quote, I think, from one of the staff participants. Don't need to read all of it, but I'll just highlight the first bit, which is what you often find is the people that should complain about things in the NHS don't. And the people that maybe aren't as hard done by as others sometimes do complain more, and unfortunately that's often the way to get things quickly in the NHS. And this very interesting contrast, it's sort of really interesting thing at the end about that trust and faith are so important for some patients in transplantation, to go through that whole process and to not lose faith in the process. Because as soon as you lose trust in someone who's going to do a major operation on you, then I think you can't really be going ahead with it. But that maybe for some patients, there might be some reason that they might be disadvantaged by the system, that they might be being unfairly deprioritized for a transplant, and maybe trust is not always the most positive attitude to hold in these cases. So that's kind of a complexity there. And finally, just skip ahead to this one, the final one. The benefits of staff not trusting TBS. Because we often talk about, the reason I'm mentioning this is sometimes people talk in terms of we need to get to people to trust AI and then we'll be able to maximize the benefits of it. But actually this staff member described the idea that, well, if I'm trusting it, I'm just going ahead with what it's recommending. And I don't want to do that. I don't trust. I've gone ahead and I've tried to understand how it works because I didn't trust that it was working well. So it can be a really positive attitude for some people involved in the design and implementation of machine learning, the designers, the clinicians exposed, to really never want to adopt a relationship of trust to it, to in fact really dig into it, really want to understand it in as much detail and complexity as possible to work out how not it's working. So just a few, the final takeaways. from that kind of study relating to machine learning that if we're concerned about opacity in machine learning, then we should be concerned way beyond just algorithmic opacity. When we're analyzing the impact of machine learning systems, really want to be analyzing the way clinicians interact with them as well, because there's often more control and interaction than it might initially be seen. And we might not always want to aim for trust in machine learning systems. Sometimes patients might be reasonable to adopt a relationship of not trusting a system, of wanting more information, of wanting some accountability. And by having clinicians that also don't adopt that mentality towards it, then you get the kind of investigations and detail in understanding how the system is working and how it's not working. So anyway, thank you very much. That's me.